to answer some of our burning questions on menopause, perimenopause, postmenopause, and specifically today we're going to dive into menopause hormone therapy or MHT. Um, and also very excited to talk about your decade by decade plan for women as they enter this new phase of life. So let's start out though talking about menopause hormone therapy, like just some sort of very high level questions. So, it's an evolving space. So tell us who today MHT would be prescribed to, and why.
Yeah, no problem. So there's kind of two parts to an assessment around whether or not an individual is a candidate for hormone therapy. So the first piece is, do I think menopause hormone therapy will be helpful for you? And I think this is important to understand because I have a lot of women that I see who maybe have a misunderstanding over how hormone therapy may be able to support them. So, menopause hormone therapy has four approvals for its use in Canada, and then one approval is throughout the world, but not necessarily in Canada. So the first is for the management and treatment of vasomotor symptoms, which is hot flashes and night sweats. And this is the area that hormone therapy has been studied the most. And when we use hormone therapy to address hot flashes and night sweats, we are expecting or aiming for about an 80%, 80 to 85% reduction in symptoms.
Hmm.
So we have a goal or a target that we're working towards and sort of setting expectations that we may not get 100% improvement, but we're trying to find the right dose that will get you to about an 80 to 85% improvement. The second area in which hormone therapy has been approved is for the treatment of vaginal dryness. So we know that local vaginal estrogen can be very helpful for the genitourinary syndrome of menopause, which are the genital changes that lead to pain with intercourse, urinary frequency, could be urinary tract infections, dryness or itchiness of the vagina.
Hmm.
Menopause hormone therapy has also been approved, but in the form of replacement therapy for women who go through menopause before the age of 40. We call this premature ovarian insufficiency. And these women actually require a higher dose of hormone therapy than we would normally give just to manage symptoms because we're trying to replace their estrogen until they get to the average age of menopause, which in Canada is about 51. We would also consider this for women who go through menopause between the ages of 40 to 45, which is called early menopause, for that same benefit of trying to narrow the window in which a woman has low estrogen compared to her peers that may go through menopause at the age of 51.
Mhm.
Not approved in Canada, but approved throughout the world, is the use of estrogen therapy for the prevention of osteoporosis. Now, this is in our osteoporosis guidelines, but menopause hormone therapy would be used off label for the prevention of osteoporosis. So, for the right candidate, if a woman has risk factors or we think she may be at increased risk of osteoporosis, then we may do a bone scan around the decision tree. And maybe if the bone mass comes back on the lower end, we would use hormone therapy to try and prevent further bone loss for the development of osteoporosis. And then there's two other areas that I'll talk to women about in which hormone therapy likely will help, but may not help. And the first is for mood. So we know that anxiety and low mood can be commonly impacted by loss of estrogen on the brain. And women who may be predisposed to having this are women that may have experienced postpartum depression or anxiety. So this would be another phase of your life in which your brain was seeing low estrogen. And so this would be something that might clue us in that hormone therapy would help with mood. If you struggled with PMS symptoms or premenstrual dysphoria, premenstrual mood symptoms, then that's also a little bit of a clue that you may be someone who's sensitive and may improve with hormone therapy in terms of mood. But when it comes to women that I see who have had long-standing histories of depression or long-standing history of anxiety,
Right.
they may have some benefit from hormone therapy, but it's not going to correct for a mood disorder.
Right.
And then the last I would say is body aches and joint pains. So we do know that loss of estrogen can cause something called the MSK, or the musculoskeletal syndrome of menopause. However, the use of hormone therapy to manage this has not been well studied. And so anecdotally, I may try some low dose estrogen to see whether or not it may cause improvement of symptoms, in the context of also having another Health Canada approved indication. And we may try and use hormone therapy just to see whether or not it would help with the body aches and joint pains.
Mm.
The three areas I get asked about hormone therapy for often are hormone therapy for weight loss.
Ah.
And hormone therapy is not a weight loss medication. So I think that's important to understand. If you are having terrible sleep, if you are having debilitating hot flashes, your ability to manage lifestyle measures, to exercise, to really be able to focus on nutrition. We know if you're not sleeping well, you're very hungry, you eat more the next day, up to
Mm.
actually 500 calories a day. But in and of itself, hormone therapy is not a weight loss medication. So we may optimize how you feel to be able to induce lifestyle
Mm.
measures or optimize your lifestyle measures, but it will not change your body composition.
Mhm.
And the second is really around prevention of dementia and prevention of heart disease. So we do not have any compelling research that would suggest the classic hormone therapy that we use, which is be a combination of estrogen and progesterone in women with a uterus, directly impacts our risk of dementia or our risk for heart disease. They
Mm.
do help with some modification of the risk factors that lead to heart disease, in terms of there may be a benefit to cholesterol, there may be a benefit to prevention of diabetes. However, the traditional ways of managing those two areas, managing diabetes, managing cholesterol, traditionally have better outcomes than using hormone therapy for
I
that
see.
management.
Okay.
So that's kind of like why we would use hormone
Interesting.
therapy. And I do think that's important because I do see many women where they feel like they're missing out, but they're actually not necessarily experiencing symptoms where I think hormone therapy may be helpful.
Got
And
it.
then the second is whether or not on an individual basis, you would be a good candidate in terms of your personal risk, your age,
Mm.
your family history, of whether or not you as an individual may be a good candidate to try it, or whether or not we would consider using something else. So, for example, if you have a personal history of hormone sensitive breast cancer,
Mm.
if you have, we would not want to use hormone therapy. If you have established cardiovascular disease, this would become a nuanced conversation. If you have active liver disease or your body is predisposed to forming clots, we might not want to use this.
Mhm.
If you are over 10 years since your last period, so it's been over 10 years since you've transitioned into menopause, the benefits of hormone therapy do start to go down, and the risks associated with hormone therapy may start to go up. Or if you're, we do know that research shows that under the age of 60, over the age of 60 does change the risk profile. So
Mm.
once again, there's kind of two pieces. Why are we using hormone therapy? And are you a great candidate or someone who I think will do well? Or is there an alternative option that I think might be worth trying first?
Okay. Thank you so much. That was an incredibly thorough explanation. I actually learned quite a bit.
Good.
My next question is around the actual product itself. So patches versus pills. I've been reading that they work differently on the body, and that there are times when you should not take pills versus a patch. So could you explain a little bit more about that?
Yeah, so once again, this is where personalized healthcare comes in because
Okay.
this is a nuanced decision. There are actually benefits to taking the pill, and there's benefits to using the transdermal patch. Once again, trying to choose or make a decision around your personal choice is important. So when you take oral estrogen gets absorbed by the gut, and then it's metabolized by the liver itself. And
Mm.
so its metabolism by the liver is really around where the risks benefits of taking oral estrogen come from. So, in terms of the benefits of taking oral estrogen, because it does directly impact the liver, it does actually have an impact on our cholesterol, which does tend to go up during the menopause transition because it does impact the cholesterol receptors on the liver that help clear the bad cholesterol.
Oh,
So, it will have an impact on our cholesterol. It is not as beneficial as taking a statin. This has been compared head to
okay.
head, but it does have a benefit. And when we look at all the trials that have looked at really the impact of um, um, estrogen on cholesterol, on cardiovascular risk, on prevention of diabetes, it really has been around oral estrogen. So the
Mm.
best studied in terms of long-term benefit has really been around oral Premarin, which is an oral estrogen, and that's what was studied in the Women's Health Initiative.
Mhm.
The downside of taking an oral medication, in terms of it being used, undergoing first pass by the liver, is that it does slightly increase your risk for developing gallstones.
Oh,
And because the liver is where we synthesize clotting factors, it does have an impact on your ability to form a clot or the development of clot.
uh-huh.
So we do think that the clotting risk that comes from taking an estrogen product when it comes to hormone therapy is increased with the oral estrogen versus the transdermal. So if you had a history of maybe a clot in your leg previously, women who maybe hasn't have a migraine history with aura and want to avoid oral estrogens. If you have maybe increased risk of cardiovascular disease, meaning you're getting a little bit older and we really want to try and avoid anything that would increase clot of the blood vessels, then
Mm.
maybe using an oral estrogen is not the right approach. But if you're a lot younger, maybe in your 40s, using a transdermal like gel or a patch is not something that you want to take on. It's easier to take a pill. It actually may be, a better choice for you in terms of maybe some benefit to the cholesterol and ease of use to use an oral estrogen. With the transdermal, because it's not going, which would be the patch or the gel, because it's not going through the liver, it's absorbed through the skin, then you do mitigate that risk for gallstones. You do mitigate the risk that we do believe it mitigates the risk for a clot to the leg as well. The other one is oral estrogen may have an impact on libido. It may decrease libido, and we don't see that with transdermal estrogen the same.
Interesting. Okay.
Yeah, I don't see it,
Mm.
and I don't see it anecdotally, I don't see it too often, but just
Mm.
a consideration once again around personal choice and maybe your goals of care. And so
Mm.
that's kind of the decision making tree. Most of the women that I speak to are a little bit older, that are, over, and I don't even mean older, but are over the age of 55. We do tend to, at least at some point, transition to transdermal. Even if you're on oral estrogen, we would
Oh,
transition. And that's just as you get
good.
older and your risk of heart disease goes up, we just want to make sure we're mitigating that risk of clot.
Okay.
But when you're younger, I really just unless there's any compelling reason to be concerned about gallstones or we're thinking about managing the cholesterol versus we want to keep the clot risk low, we'll make a
Mm.
decision around oral versus transdermal.
Okay. Very interesting. And so once you're on the medication, how is it managed? I mean, do women get their blood tested regularly for hormone levels, or how do you assess whether or not the therapy is working?
So really, it's about symptom management, especially when we're talking about menopause hormone therapy for symptom management. So this is
Mm.
really, the first three indications that I talked about, which was, using it for hot flashes and night sweats. If we're using hormone therapy for mood, if we're using it, to see if it has an impact on joint pain, although I will not push estrogen for that. We're really looking for that 80 to 85% benefit
Okay.
that I mentioned around the vasomotor symptoms. And so I will, you try and match the lowest dose that gives that, benefit
Okay.
when it comes to what the appropriate dosing should be. There are side effects to your estrogen dosing being too high. It can cause you to feel pregnant. It can cause
Oh.
breast tenderness. It can induce migraine. It can cause vaginal bleeding. So
Oh.
we want to kind of use the dose that you don't struggle with the side effects of too much estrogen, but are able to manage that, manage the reason why we use the hormone therapy in the first place.
Mm.
I don't tend to do blood work around effectiveness unless there's a concern about absorption. So if someone was using a patch or a gel and they weren't getting better, and I was pushing the dose and their hot flashes were not getting better at all, then I would start to question, like, are you even absorbing the
Uh-huh.
medication? And so we might do blood levels then.
Okay.
When it comes to prevention of osteoporosis, basically all of the doses that we use for estrogen have been shown to preserve bone mass or be helpful for preventing osteoporosis.
Mm.
So we wouldn't do blood work for that as well.
And so you talk about prevention of osteoporosis. Is it ever used off-label for someone who has osteoporosis?
It is used off-label for someone who has osteoporosis, but it's not what I would recommend.
Uh-huh.
If someone is refusing to use a bisphosphonate or refusing to use one of the anabolic agents or an osteoporosis medication, maybe they don't tolerate it, then we can use estrogen, but it hasn't been as well studied
Okay.
in terms of treatment of osteoporosis, and it doesn't have the same robust evidence that
Mm.
the other osteoporosis agents do. So it's really around, like, the most robust evidence for this is really around prevention of osteoporosis as
Mm.
opposed to treatment.
Okay. All right. Excellent. Now, what I would love to hear about is the decade by decade action plan that you've come up with. And I'm going to be talking about it at the Menopause Show in Toronto.
Yeah.
So would love to hear about that. Have a sneak
Yeah.
peek.
I'm happy to give you a sneak peek.
Thank you.
So, we just spent a lot of time talking about hormone therapy. And to your point, I mean, there's a lot of buzz happening around the perimenopause and menopause space right now, which is very positive and can definitely be overwhelming to your point. But it's
Yeah.
really focused around accessing and the importance or the education around hormone therapy.
Okay.
But when we look at women as they're going through the perimenopause and menopause transition, this is actually a period of time in which we see a pivot in terms of our risk of chronic disease.
Mm.
So, the diseases that impact women the most as we get older are osteoporosis, which we just discussed, our heart disease, the number one cause of death for women, dementia, and then cancer. And I find that there's a missed conversation happening around really having a prevention plan in terms
Mm.
of mitigating that risk because it's being overlooked by accessing hormone therapy. And both can be, the importance of both can be true. It's just important to understand having a comprehensive health approach. So, when I talk about the decade by decade plan, it's really understanding when we start to see your risk of disease go up, and then what role you can play in terms of trying to mitigate that risk. Because we do know that we as individuals have the power to change a lot of the risk for both heart disease, for cancer, deaths by screening, and even we know we have about a 45% modifiable risk when it even comes to dementia.
Mhm.
So when we talk to women, I talk to women in their 30s. It's really about paying attention to anything related to pregnancy complications because we do know that female specific risk factors are often overlooked when we try to risk stratify or try and calculate what your risk of heart disease is. So if you have a history of gestational diabetes, if you have a history of gestational hypertension, these actually have a significant risk on your risk of heart disease later on. We think
Mm.
that these, when this happens during pregnancy, it's almost like a stress test. It's like
Mm.
when your body's maximally stressed, does it show a little bit of insulin resistance or trouble with glucose regulation? Is there an impact on the blood vessels? And so this can be a sign that you are at increased risk for developing diabetes or high blood pressure later on, and shouldn't be ignored. You should have your cholesterol closely looked at and your blood pressure watched as you get older. If you have a history of polycystic ovarian syndrome, we do know that that increases your risk of developing type 2 diabetes, and so something to pay attention to in your 30s. And then the third would be anyone who loses their periods in their 30s should be worked up for premature menopause, which I spoke to you about earlier, because we do know that loss of estrogen for more than 10 years from the average age does have a significant impact on our risk of heart disease and dementia and osteoporosis. And even in the last 3 weeks, I've seen 2 women that were missed with this diagnosis. And this has like very serious consequences. And so you should pay close attention to that. When it comes to your 40s, this is when we start to see the perimenopause stage happen. And so most women going through perimenopause will have a period of actually higher estrogen before their estrogen goes down. And this presents as actually really heavy periods. And so a lot of women experience heavy periods. You may develop fibroids. And so a couple of pieces to this plan is, one, this often leads to significant anemia and low iron, making you feel terrible. And 2 is actually manageable. I've had women bleeding on the chairs when I'm seeing them, and it's been almost normalized, and I'll say they'll be like, oh, my period's not that bad, but I'm changing a Super Plus tampon every 2 hours. So there's a lot of heavy bleeding happening, a lot of women feeling terrible and tired, and it's not being managed. And this is usually a sign that you're starting to enter perimenopause. Cancer screening really should start in the 40s with breast cancer. You should be having PAPs in your 30s, but breast cancer screening should start in your 40s. And you should understand what your breast density is. So women who have higher breast density, so category C or D, are at increased risk for missed cancer diagnosis on mammogram, and should advocate for breast ultrasound. Because it will pick up more cancers, a mammogram plus an ultrasound together.
Quick question. How do you determine your breast density?
It can only be determined by mammogram. You cannot feel if you have dense breasts. So as of 2 years ago, Ontario breast screening program mandatorily mandates that you are told your breast density. So you will get that letter. Before 2 years ago, it wasn't mandatory, so you may or may not have gotten it, but you should know if you've had a mammogram in the last couple of years.
Okay, thank you.
The other thing we really start to see in the 40s is the cholesterol starting to creep up. So having an annual cholesterol check, especially if you have risk factors or family history of high cholesterol, is something to pay attention to. I'm not going to get into lifestyle measures because they are kind of the same as we go on. When it comes to your 50s, this is when most women are starting to go through the menopause transition. So if you are starting to skip periods, if you're starting to develop vasomotor symptoms, so hot flashes and night sweats, if you do not feel like yourself, if you're developing mood symptoms, once again, this is in keeping with the menopause transition. We do not need to do blood work to confirm this. There are treatment options available, and as just discussed, lots of options. Colon cancer screening should start in your 50s. And this is when we really start to see a change in cholesterol. So definitely cholesterol annually. And when the blood pressure starts to creep up. And I usually recommend a conversation in the 50s about whether or not you are at risk for osteoporosis. Right now, the current guidelines suggest that this is discussed at 65. And I think
that's crazy.
And because our guidelines are looking for osteoporosis, they're not around prevention of osteoporosis.
Oh, I see.
And I think that we should be having the conversation, because if you're 65 and you have osteoporosis, you've missed that window to be able to use estrogen, to be able to use strength training, to be able to use nutrition to really support, preventing bone loss.
Right.
And then we talk a lot about in your 50s is really that window of modifiable risk for dementia prevention. So hearing loss in your 50s actually has a 7% risk for developing dementia. And I've actually picked up on quite a bit of hearing loss in my clinic. I think it's
Yeah.
about 10%. So having your hearing checked, especially if there's any concern, is something that I would consider. The other modifiable risks that really start to present in your 50s are elevated cholesterol, increased alcohol intake, sedentary lifestyle, smoking, high blood pressure, and diabetes. And so once again, optimizing our risk factors to try and prevent disease can have a significant impact in 10, 20 years
Right.
later.
Okay.
And then once you're in your 60s, if you weren't able to, and 70s, if you weren't able to have that screening done in your 50s for osteoporosis, this is when osteoporosis really does start to present itself. Understanding whether or not you have osteoporosis, advocating for getting a bone scan is an important piece to this. All the cancer screenings should be continuing. And then this is really when we start to see hypertension present. Almost 70% of women over the age of 70 have elevated blood pressure. So,
Really?
yeah. And so
Wow.
this is really, once again, there's interventions. We can use lifestyle measurements. We know that nutrition can make a big difference, but because you don't feel high blood pressure, keeping a close eye on it is really important.
Mm.
You basically got my talk.
That's fantastic. Thank you so much.
You're
Now,
welcome.
second last question. What kind of MDs should women trust for their menopause care? Because I have learned over time that not every doctor, not every gynecologist, not every family doctor actually has the education to give women the proper care.
Yeah, so change is coming.
Okay.
Change is coming. So just last week, Ontario Health released new quality standards around menopause for primary care physicians.
Oh,
So these are expectations. There were 6 expectations that family physicians in Ontario need to adhere to and will actually be measured and tested over the next 5 years. And one of these quality standards is that your doctor proactively brings up the menopause transition and uses it as an educational opportunity to kind of let you know about what to expect and also, educate you around risk of disease. So I do think these quality standards are a massive move in terms of enforcing how important this is,
mhm.
prioritizing education around menopause for family doctors so that these quality standards can be met. Um, I mean, it's going to take time for physicians to be able to feel comfortable with this,
Yeah.
but it's coming. In the meantime, probably the best way to understand is to go to the Menopause Society site. This is the United States organization. It used to be called the North American Menopause Society, but they offer an exam twice a year that's challenging that you would need to study. You can't just write, like you would need to study for and prepare for and be well versed in menopause care
Mhm.
to pass and receive the qualification. And it's called the MSCP designation. And on their website, you can see all the Canadian physicians that have obtained that MSCP designation. So you can search by where you live and would be able to see be able to see or understand who in your neighbor area may have this extra training.
Okay. Good to know. And finally, so what are there sort of, top 3 or 5 questions that women should be asking proactively of their healthcare provider about their perimenopause or menopause transition?
So if I was going to bring up any questions about I really think it should be around the disease prevention piece. I do think that menopause is an opportunity to really get serious about your health and
Mm.
take some time to become health literate about like what should I have on my radar for the next 10, 20 years.
Yeah.
There are a lot of women who are not bothered by the menopause and perimenopause transition. And
Oh,
so if you are not having hot flashes, if you are not having night sweats, Like you don't have to go on hormone therapy. You're not missing out.
Yeah.
And alternatively, if you don't tolerate hormone therapy, I also think advocating for like what else is available to me, I think is an important question. So I would say it really depends on how you feel.
Yeah.
But I do think if you are symptomatic, book your doctor's appointment as only to be addressing your menopausal symptoms. It's important enough that it's not part of a list of things you would like to address.
Hmm.
You really want your appointment to be only about this. I think being able to articulate specifically what you are experiencing and how it is impacting you, I think will be very helpful. If you just say you're feeling hot, it doesn't it doesn't go as far as saying, I am having 20 drenching hot flashes a day and I need to bring a change of clothes to work to even be able to function.
Right.
It really does articulate how it's impacting your life. And then the other piece I would say, what in terms of asking a question, is as soon as you leave, ask when you will be following up, because I do think it's really important that there's a check-in, around 6 weeks after initiating any medication,
Mhm.
because no physician's going to get it perfect out the gate. And there's so many options in terms of alternating dose, delivery of the medication, that having that checkpoint so that if it's not working, if you're having symptoms, if you're actually not tolerating the medication, there's a booked appointment in place to be able to discuss how you're doing.
Right. Dr. Amy, amazing tips, fantastic information. I can't thank you enough for your time today.
You're welcome.